وطبعا الدكتور حسام العربي غني عن التعريف، يعني هو استاذ القلب في كليه طب اسيوط ونجم الصعيد بتاعنا وبنشرفنا في كل اللقاءات العلميه، وهيكلمنا على التوب 10 مسج ان ESC Acute Coronary Syndrome Guidelines. اتفضل يا حسام.
شكرا على الدعوه المؤتمر، وبشكر الدكتور محمد انور والدكتور عبد الناصر. هي البرزنتيشن على الاي سي جايد لاينز فور ذا تريتمنت اوف اكيوت كوروناري سيندرومز. احنا عندنا 10 مسجز هنتكلم عليهم. اول واحده ان هي 1 جايد لاين فور اول اكيوت كوروناري سيندرومز. الجايد لاينز اللي قبل كده كانت ستيمي ليها جايد لاينز، نون اس تي اليفيشن ام اي والانستيبل انجينا ليها جايد لاينز. لكن actually this is a disease sharing the same pathophysiology, the same clinical presentation that varies from asymptomatic chest pain that is mild or severe agonizing chest pain up to cardiogenic shock and acute heart failure, and even a presentation with cardiac death. The investigations with ECG and working lab can differentiate this syndrome into different etiologies: unstable angina, non-ST elevation MI, and ST elevation MI. The treatment of this syndrome shares main lines. After diagnosis and classification of acute coronary syndrome, think about invasive management. Invasive management using PCI or CABG is common among all the classification types with different indications. Then think antithrombotic therapy, aspirin, P2Y12 inhibitors, anticoagulant therapy, the same for all types of acute coronary syndromes. And when thinking revascularization strategy, it's based in all types about clinical status, comorbidities, and disease complexity. And the aim is complete revascularization, and consider adjunctive tests with intravascular imaging and intravascular physiology. And then we think about secondary prevention, sharing the same lines for secondary prevention. The second message is recommendations of out-of-hospital cardiac arrest. The recommendation for out-of-hospital cardiac arrest is evaluation of neurogenic prognosis no earlier than 72 hours after admission with a class 1 indication. And then transport of patients with out-of-hospital cardiac arrest to cardiac arrest center is class 2A according to the local protocol. The concept of therapeutic hypothermia that was in the previous guidelines, keeping temperature between 32 and 36 for at least 24 hours in patients who remain unconscious after resuscitation from cardiac arrest, is changed to active prevention of fever with maintenance of temperature less than 37.7. And this is a major change in the recommendations in the guidelines. It's class 1 recommendation. The message number 3, recommendations for invasive strategies. No change regarding the timing. The role of 120-minute rule for first medical contact to wire remains. For patients presenting to PCI center, it's better to wire crossing less than 60 minutes. In patients presenting to non-PCI capable center, transfer the patient to PCI capable center with wiring in less than 90 minutes. This is the same recommendation. If no, then the aim is fibrolytic therapy in less than 10 minutes, and then transfer the patient to a PCI capable center. The recommendation for indication for primary PCI is STEMI less than 12 hours from presentation, 12 to 48 hours with either symptoms, active ischemia, or hemodynamic instability is class 1. As a routine, even in the absence of these three associated signs or symptoms, is class 2A. After 48 hours is class 3. No primary PCI after 48 hours of the start of persistent chest pain. The timing of intervention in non-ST elevation MI is classified to very high risk category with hemodynamic instability or cardiogenic shock, recurrent or ongoing chest pain, refractory to medical treatment, acute heart failure, life-threatening arrhythmias, mechanical complications, the recurrent dynamic ECG changes, suggestive ischemia. It is very high risk with immediate invasive strategy, class 1, or can be less than 48 hours early invasive strategy, class 2A. It is better to be done immediate, but it can be done within 24 hours. In high-risk population with confirmed non-ST elevation, enzymes are raised. This is the diagnosis, or GRACE score more than 140, transient ST elevation or dynamic ST wave changes. It is considered as high risk with invasive strategy within 24 hours. In absence of these high risk and very high risk criteria, according to index of suspicion, with high index of suspicion, inpatient invasive strategy before discharge is considered class 1, and in low index of suspicion, selective invasive after non-invasive assessment either by CT, coronary, or by ischemia detection, exercise techniques for ischemia detection. The message number 4 is in multi-vessel disease, in cardiogenic shock, immediate PCI in the infarct-related artery only is a recommendation, and complete revascularization in a staged approach within the same admission. In STEMI patients, complete revascularization in the index procedure can be done, or within 45 days is the current recommendation. It was class 2A, it is now class 1. In non-ST elevation myocardial infarction, complete revascularization is class 2A recommendation, and functional invasive evaluation of non-infarct related artery by FFR or IFR in the index procedure is class 2B. The guidelines came from the PRIMA trial, in which complete revascularization was done in the index procedure with better outcome, and this made the American guidelines to recommend complete revascularization in the index procedure as class 2A in the previous guidelines, and culprit trial, in which complete revascularization within the same admission showed better outcome, called complete revascularization compared to culprit only, and this made the European guidelines to recommend the completion of revascularization in a staged approach within the same hospital admission in the previous guidelines as class 2A, and then complete trial, which showed better outcome with complete revascularization within 45 days, and this is the current recommendation, that is class 1 indication. Message number 5, recommendations for antiplatelet therapy. Regarding antiplatelet therapy, unfractionated heparin in STEMI, unfractionated heparin is class 1, enoxaparin class 2A, bivalirudin class 2A, and fondaparinux, of course, is class 3, because these patients are going to primary PCI. In non-ST segment elevation myocardial infarction, unfractionated heparin is class 1, and if angiography is to be done in the first 24 hours, enoxaparin is class 2A and is switched to unfractionated heparin during the procedure, and if angiography more than 24 hours, class 1 fondaparinux. Routine antiplatelet treatment with aspirin is recommended. Pre-loading with P2Y12 inhibitors is now class 2B. It's better to load on table after coronary angiography, after knowing the anatomy. In non-ST segment elevation MI, preloading is class 3 until coronary angiography is done. In acute coronary syndromes, prasugrel, ticagrelor are recommended, and clopidogrel only if those drugs are not available or not tolerated. And proceed to primary PCI, prasugrel is preferable class 2A compared to ticagrelor. After PCI, continuation of DAPT is 12 months. This is class 1, and after 1 year of DAPT continuation with aspirin is the traditional strategy with class 1. Some deviations occur in patients associated with high bleeding risk. It is abbreviated to 1 month of DAPT followed by P2Y12 or aspirin monotherapy. It is class 2B. In patients with either high bleeding risk or non-high bleeding risk with event-free or not at high ischemic risk, stop of DAPT at 3 months class 2B or 6 months class 2A, and the continuation with monotherapy with one of the antiplatelets. De-escalation from prasugrel or ticagrelor to clopidogrel is contraindicated in the first month after PCI, and this class to be done if acute coronary syndrome is old, especially in high bleeding risk. This is because the trials that the trials that showed that high bleeding risk recommend abbreviation of therapy are primarily powered to show non-inferiority rather than superiority of this technique, and often excluded patients or underrepresentation of patients with high risk of acute coronary syndrome. So consider high ischemic risk better than high bleeding risk. This is the new strategy in the guidelines. Message number 6, recommendations for antithrombotic therapy in patients indicated for anticoagulations like AF patients. The default strategy is triple therapy with clopidogrel, aspirin, and NOAC or warfarin. And you can, after 6 months, go to monotherapy with anticoagulation, but this is class 2B. In the presence of high ischemic risk, it is class 2A to continue the triple therapy for 1 month, then go to DAPT for oral anticoagulants plus single antiplatelet therapy, and after 1 year you go to NOAC only. The use of ticagrelor or prasugrel as a part of triple therapy is contraindicated. Recommendations for acute coronary syndrome comorbid conditions: aspirin is not recommended with platelet count less than 10,000 and clopidogrel less than 30,000, and prasugrel or ticagrelor less than 50,000. And for blood glucose control, the old guidelines recommended blood glucose control more than 180 and avoidance of persistent hyperglycemia. Just 2 minutes. Message number 8, recommendations for long-term therapy, secondary prevention. The recommendation for secondary prevention, discharge on cardioprotective medications, start lifestyle management, outpatient department interview is very important to discuss with the patient the further management and the goals and the benefits of this preventive management strategies that they will adopt after acute coronary syndrome. It consists of support healthy lifestyle choices, smoking cessation, healthy diet, regular exercise, healthy weight, psychosocial management, antithrombotic therapy, lipid-lowering therapy, influenza vaccination, and promote drug adherence and persistence. And the targets for hypertension 130 and 130/80, and LDL cholesterol less than 55, and hemoglobin A1C less than 7%. Patients with high ischemic risk or without high bleeding risk, adding second thrombotic agents to aspirin for extended term therapy is considered 2A. In moderate ischemic risk, it is class 2B. P2Y12 inhibitor monotherapy is considered as class 2B. And high intensity statin therapy, class 1, adding ezetimibe is class 2B, and low dose colchicine 0.5 once daily may be considered, particularly if other risk factors are insufficiently controlled or if recurrent cardiovascular disease events occur under optimal therapy. And this is the traditional strategy recommended for the dyslipidemia guidelines: start high intensity statins, then ezetimibe, and then PCSK9 inhibitors. The 9th recommendation, Emergency TEE is recommended in patients with suspected cardiogenic shock or mechanical complications. Transthoracic echo as a triage in case of diagnostic uncertainty, class 2A, but this shouldn't delay the cath lab, and routine early calcium CT is not recommended, and the use of CT is downgraded from class 1 to class 2A, and CMR as an alternative to echo from class 2A to class 2B. And finally, the recommendation of patient perspective. Discussion with the patient is very important. Explain the procedure to the patient. Ask the patient to repeat what you said, and then review the points missed by the patient, and ask the patient again to repeat what you said. This is very important. The patient should know exactly what you are doing to do. Thank you.